Well, thank you, Ellie. It's wonderful to be here with all of you again for our first of the breakout sessions. This breakout session is going to be on federal data linkage strategies for enhancing health and healthcare data, organized by Aubrey Limburg from the Census Bureau and moderated by Stefan Gildemeister from the Minnesota Department of Health. So let's go ahead and bring Stefan on stage. And Stefan, will you take it from here?
I'm happy to. Good morning, everyone. I'm just really thrilled that everyone is joining NATO's 37th annual conference, and particularly that you're participating in today's fabulous session on federal data linkage strategies. I have the privilege to moderate today's session. My name, as Norm introduced me, is Stefan Gildemeister. I direct the Health Economics program in the Minnesota Department of Health, and I'm a board member at NATO. For today, we have three speakers who are at the U.S. Census Bureau, and we're excited to connect with federal partners. Just briefly, we'll organize the time available in the following way. I will briefly introduce each speaker before we stream their recorded presentations. After the presentations, we have a little time to take questions before we move to the next speaker. And following all presentations, we'll bring everyone together as a group for discussion and to answer questions. But before we invite the speakers to hear their presentations, we'll hear a brief introduction by Lucinda Dalswell, who is Survey Director of the National Ambulatory Medical Surveys and Acting Program Manager of the Enhancing Health Data Team, eHealth, at the Census Bureau. Let's go to Lucy.
Everyone, I'm Lucy Dalzell, a Program Manager and Survey Director at the Census Bureau. The mission of the Census Bureau is to serve as the nation's leading source of quality data about its people and economy. Within the context of health, this includes addressing questions about patients, providers, the broader healthcare system, and the broader population. Our traditional toolbox for addressing these questions has been surveys. Yet we know that surveys cannot always address these questions quickly enough, cheaply enough, or completely enough. This is particularly true today as we witness steady drops in survey response rates. For this reason, the Census Bureau has expanded its toolbox in the areas of data science, administrative records, and data linking as a complement, or in some cases, a substitution to our surveys. This is particularly exciting and promising work in the health world, given the opportunities presented by large-scale electronic health records. To take advantage of these opportunities, we launched the Enhancing Health, or eHealth program, to serve as our hub for strategically reusing existing health data. And today, we are excited to share some of the projects that we've been working on. Our first presenter, Alice Zawacki, will discuss the Medical Expenditure Panel Survey insurance component with administrative records. This work demonstrates the power of combining survey and administrative data and highlights the data linking capabilities at Census for enriching data on both workers and businesses. Second, Aubrey Limburg will present linkage of Medicaid data to our rich demographic data to fill in missing race and ethnicity information, and thereby improve researchers' ability to study the social determinants of health. Third, Dennis Linders will present a newly initiated project that looks at the supply side of healthcare by linking external and Census Bureau data on physicians and their employing organizations, so that we can examine the trends that are restructuring the business of healthcare. And then tomorrow, I will be participating in the federal panel, where we will continue to explore the ways that the Census Bureau can collaborate with other governmental and non-governmental organizations.
Perfect. Thank you, Lucy, for that introduction and also for introducing the speakers. There is a rich information on people's biographies in the app, but I'll say a few words about Dr. Alice Zawacki. She's a senior economist at the U.S. Census Bureau, where she's the agency's lead economist for the MEPS insurance component and the management and organizational practices survey that includes hospitals. We will queue up Alice's presentation now, I think.
Hi, I'm Alice Zawacki, and I'm going to introduce the Medical Expenditure Panel Survey Insurance Component with Administrative Records, or MEPS-ICAR. This work is done in collaboration with Thomas Hegland and Ed Miller. The MEPS-IC is collected by the Census Bureau. It's sponsored by the Agency for Healthcare Research and Quality. It asks businesses about health insurance offerings for employees. It's an annual survey, first conducted in 1996. It has both a private list sample, which we're using in the MEPS-ICAR, and also a sample of state and local government units. And the URL here provides more details about the survey. Two concepts that are important and will also be relevant to Dennis Linders' presentation is establishments versus firms. If a firm operates one establishment, it's called a single unit. If they operate more than one establishment, it's a multi-unit. An establishment is the physical location where the business activity takes place. You can think of your local ice cream shop at the corner of 5th and Main. The MEPS-IC collects a number of measures at the establishment level, including employment size, the number of employees eligible for health insurance, the number enrolled in these benefits, other non-wage benefits, including sick leave, vacation time, disability insurance, and pensions, and the percent of workers who are women, 50 years of age or older, working part-time, belonging to a union, earning a low, medium, or high wage. If an employer says they offer health insurance, we also collect data on up to 4 plans, including the provider arrangement, whether it has a gatekeeper, what's the coverage level. By coverage level, we collect data on premiums, premium contributions, and enrollment, as well as out-of-pocket expenses. The sampling frame for the MEPS-IC is the business register, and so the data contains some measures from the frame, including single and multi-unit firm status, industry, geographic location, payroll, and employment size. So now I'm going to turn to how we construct the MEPS-ICAR, and our objective here is to match workers and their socioeconomic characteristics to employers sampled in the MEPS-IC. And these are important measures when we want to understand this group insurance market. Two identifiers that I'm going to talk about now before I get into the linkages are important and also relevant to Aubrey and Dennis's presentations that you'll hear shortly. When the Census Bureau ingests the tax filings, as well as when it processes the decennial data, these are put through the Person Identification Validation System, or PVS, which removes identifying information. It also assigns protected identification keys, or PICs, and we can use these to link the tax filings with the decennial data. The business identifier that we use is the Employer Identification Number, or EIN. And in firms A and B shown here, the EIN uniquely identifies the establishment. However, in firm C, they use the same EIN to file taxes for each establishment, and so it is not a unique establishment identifier. And this is important as you hear about our linkages. So to get started, we're using data from the MEPS-IC for which we have tax records. And our first task is to obtain all the EINs for firms with establishments in the MEPS-IC sample. We do this using an internal establishment identifier and link the MEPS-IC back to its sampling frame. And as a result, we have a data set with all the EINs for firms represented in the MEPS-IC sample. Along with this, we're also amending the W-2s with worker residential addresses and socioeconomic measures by linking the W-2s to the Form 1040s and the decennials from 2000 and 2010 using PICs. And as a result, we have a data set of W-2s with worker characteristics. So in our second task, we can now link these two resulting data sets from task 1 by EIN to then match worker characteristics to MEPS-IC firms. So this is our first MEPS-ICAR dataset. Now our final task is to match workers in the firms to the establishments. And as I mentioned, the EIN doesn't uniquely identify these establishments, and so we use workers' residential addresses relative to the establishment's physical location, as well as establishment targets, including employment, payroll, and the distinct number of expected W-2s. As a result, we have data on workers, including personal income, age, sex, race and ethnicity, marital status, where they live, and their commuting distance. We also have information on the worker's family income from their MEPS-IC job, as well as the number of income-earning individuals in the family and the number of dependents and exemptions. We also construct an annual employee turnover rate, since we now can create the total number of hired and separated workers. In terms of quality, we have a 93% match rate, which describes both the MEPS-IC establishments linked to their workforces, as well as MEPS-IC reported employment to tax records. And this match rate is consistently high for most years, census divisions, industries, and size categories. Our match rates for the multi-unit firms are similar to those in the single-unit firms. We also compare worker commute distances between the MEPS-ICAR and the National Household Travel Survey, and these distributions are quite similar. So this suggests that we have both realistic commute distance distributions as well as the correct worker establishment assignments. It's important to point out we do not observe whether the individual workers obtain coverage from their employer, and if they do, which employer plans they're enrolled in or what type of coverage they have. What we do know are the health insurance choices offered by their employer, and we know enrollments at the establishment and offered plan level, but we don't know the actual choices particular workers make among the options offered. So in conclusion, this is the first and only nationally representative business data set that characterizes both the employer's health benefit packages as well as providing detailed socioeconomic information about the workers and their families. It also helps to expand on employer-sponsored health insurance analyses, including whether these benefits vary by the workforce's personal and family characteristics, whether these offerings affect labor mobility, because we have this new measure of turnover. We can also study the trade-off between offering more generous health benefits and higher wages. And at the state level, there can be analyses done on the impact of policies, given that we know the workers' residential addresses and income. In our next steps, what we're going to do is evaluate using the American Community Survey health insurance coverage of workers to bring in more information on whether they have employer-sponsored coverage. We also are going to be evaluating the creation of MEPS-ICAR files that would be available to approved researchers, and our plan is to update these files annually. Thank you.
Thank you, Alice. And apologies that the video didn't work for you. Alice, I wonder if we could ask a few questions and see if there are any clarifying questions coming in from the audience. I think one question I want to ask is, who gets to use these data files?
So there is an application process that researchers will go to the Federal Statistical Research Data Centers, which there are approximately 30 located across the country at many academic centers and at the Federal Reserve Bank System. You can find locations, and our website has those listed, and approach an administrator and talk about what ideas they have for requesting access to these confidential data. The data can only be used within this research data center network because the MEPS-IC includes data from the IRS. So they're protected under Title 26, and these data cannot be downloaded off the internet or anything like that. They have to be used within a secure environment. And then there are rules for reviewing the output and to be sure that no businesses nor individuals can be identified from the output that the researchers produce. And those proposals are reviewed by the Census Bureau, in this case also the Agency for Healthcare Research and Quality, and the IRS. And once approved, researchers then go through the process, some logistics for getting into the lab and working with the data.
Yeah, that sounds good. I think we're familiar with some of these research data centers in other work that we've done. Can you talk a little bit about the number of observations in the MEPS-IC, and then you have a high linkage rate, which is of course great, but how big is the data set, and what granularity can researchers use sort of by some common stratifications, maybe geography, maybe firm size, maybe other characteristics, industry?
Sure. So the sampling strata does include firm size, establishment size, and state. And the data does support state level estimates given the sampling design. In the early years of the MEPS-IC, and I see a message in our chat about, states having an option to buy larger samples, and that might still be an option. That would be a question our production staff would be able to answer better than I can. But currently, in the early years, some states were rotated and the sample sizes were adjusted, and so not all states in all years could have support estimates. But then many years ago that did change. All states now have a sample size sufficient to support those estimates. So I got off track there a little bit. Stefan, does that answer your question? I mean, there are about 40,000 establishments in the sample each year. It's varied. It has grown over time, and now that is also split between the private sector establishments, and then there is the sample of state and local government units. So it's about 40,000 in total.
Yeah, thank you for that. Maybe one more question, and then we'll come back to Tom Bell, who has two questions in the open sessions. The question from Sarah Lindberg is, in the past, states had the option to buy into the MEPS-IC sample. I'm not sure to what extent that extends to the ICAR linkage, but are you familiar if that's still an option for states who wish to know more about their establishment picture?
Yeah, as I mentioned earlier, that I think that was a little bit more common when the sample for each state wasn't large enough to produce estimates at the state level. We don't release these due to different confidentiality reasons, except for state and local governments. The private sector state level estimates are not released, but we currently sample so that each state can have MEPS-IC samples produced that will support those, state level estimates. But it certainly may be an option. Production staff, and you have my contact information, and I would say feel free to follow up with me, and I, work with the production staff on details like, can people still purchase a larger sample for their state?
That sounds good. And then Alice, we'll come back to you after we've heard from Aubrey and Dennis. Maybe two questions for you to think about are the ones from Tom Bell in the list, but also maybe a third one for us to talk about in a group is how will we know and learn about the research that comes from this data set? Sort of how do we as analysts or policymakers stay connected with this interesting work? So that's that. We'll put that in the parking lot, and let's move to to Aubrey. Dr. Aubrey Limburg is a survey statistician in the Enhancing Health Data or eHealth program at the U.S. Census Bureau. She focuses there on creating unique and novel data linkages, and I think she will tell us about some of those. Aubrey, go ahead.
Hi, everybody. Thank you for taking the time to join us. My name is Aubrey. I am a survey statistician at the U.S. Census Bureau working in the eHealth program. Today, I'm going to be sharing with you some research we've been working on linking national Medicaid enrollment data to Census Bureau data as a means of studying racial and ethnic disparities in health. So this project was motivated by a high rate of missing race and ethnicity information for beneficiaries in Medicaid enrollment data. Given this missingness, our goal was really to evaluate the impact of missing race and ethnicity among beneficiaries on our ability to estimate racial and ethnic disparities in health. And we focused on all-cause mortality. And we were able to accomplish this by taking a data linkage approach in which we linked national Medicaid enrollment data with a variety of census data sources. So for our presentation today, I'm going to walk you through the record linkage, some of our main findings, and then spend a bit of time discussing the implications of this kind of novel data linkage for studying health. So I'll quickly give you some info about the race and ethnicity measure we were using. Census does collect race and ethnicity as separate measures, but Medicaid only makes this available as a single collapsed measure. So we primarily relied on a single measure of race and ethnicity, focusing on 4 broad categories: Hispanic beneficiaries of any race, as well as white, Black, and other race beneficiaries who did not identify as Hispanic. We also did conduct some additional analyses with a detailed race ethnicity measure that broke the other race category into Asian, American Indian, Alaska Native, Native Hawaiian Pacific Islander, and multiracial. So I'll start by describing our approach to you. So for Medicaid data, we relied on the 2016 Transformed Medicaid Statistical Information System analytic files. These data include information for all Medicaid and Children's Health Insurance Program, or CHIP, beneficiaries for 2016. For census data, we combined race and ethnicity information from the decennial census for both 2000 and 2010 with American Community Survey, or ACS, data from 2001 to 2019. And then for mortality data at census, we relied on date of death information from the Census Numident file, which is our version of the Social Security Administration records. And as Alice has already mentioned, the data linkage was done using a protected identification key, or a PIC, which is an individual level anonymized identifier that's common across all data sources at the Census Bureau. So overall, our PIC rate was really high. Nearly 98% of beneficiaries in Medicaid data received a PIC. So we were able to find them in census data sources. And although someone may have received a PIC, this doesn't actually mean we were able to find race and ethnicity information for them in decennial or ACS data. So this is what we call our linkage rate, or the percent of beneficiaries we were able to actually find race and ethnicity for in at least one of our census data sources. And this ended up being about 70% of all Medicaid beneficiaries. So on average, 19.47% of all beneficiaries were missing race and ethnicity in Medicaid data across all states. And here we show the percent of beneficiaries in each state who have missing race and ethnicity. And you can kind of see that there was a lot of variation in the level of missingness across states. Only 15 states had less than 10% missing. 7 states had more than 50% missing, and 3 of those states were actually missing race and ethnicity for all beneficiaries. However, after we linked census and Medicaid data, we saw a 63% decline in the number of beneficiaries with missing race and ethnicity, so down to 7.11% from 19.47. And you can see here that the majority of states actually now had less than 10% of their beneficiaries missing race and ethnicity. So even though we were able to provide race and ethnicity information for 63% of beneficiaries who were originally missing this information, there were instances in which a beneficiary could have race and ethnicity in both Medicaid and census data that actually weren't concordant. So this made it really challenging to kind of move forward with identifying the impact of missing race and ethnicity on estimating race-specific all-cause mortality. So to harmonize race and ethnicity between the two sources, we constructed a new race ethnicity variable in addition to the original Medicaid race variable, which was just the observed race ethnicity of beneficiaries in Medicaid data. And we called this the prioritized race approach. And so for this approach, we combined Medicaid and census race, but for beneficiaries with discordant race and ethnicity between the two sources, this approach prioritized the smaller race and ethnicity group as identified by the 2010 census population. And this is based off of work that has been done by others at Census and verified. So given this new race variable, we could now actually evaluate the impact of missing race and ethnicity on estimates of race-specific all-cause mortality. So to do this, we compared the mortality rate based on Medicaid race to the mortality rate based on the prioritized race approach. And then we ended up with this mortality rate bias. So then we plotted the mortality rate biases for all states and for each race and ethnicity group. Here we show the mortality rate bias comparing Medicaid race and prioritized race. So a negative value suggests that we actually underestimated mortality, and then a positive value means that we were maybe overestimating mortality. So for the majority of states, missing race and ethnicity in Medicaid data didn't actually appear to pose a significant problem to the estimation of race-specific mortality rates. However, there were some important exceptions. So here you can see there were higher amounts of mortality rate bias for Hispanic and white beneficiaries relative to Black beneficiaries. Additionally, there were several states who over or underestimated mortality. So for example, for Hispanic beneficiaries who lived in Wyoming, so that green dot right there, the mortality rate was underestimated by 67.2 per 10,000 beneficiaries. Although we don't show this here, there were also important differences based on the age of beneficiaries. So this suggests that researchers reliant on Medicaid data with missing race and ethnicity should evaluate how their results may be constrained or limited. So in sum, this research had a few important implications for health data and the research that relies on this data. So first, our work suggests that it is possible and effective to link Medicaid and census records, and this was demonstrated by a high pick and linkage rate that allowed us to kind of leverage the unique potential of these disparate data. Second, our results have implications for other kinds of health records beyond Medicaid enrollment data, including electronic health records, health registries, inpatient, outpatient data, and emergency department data, just to name a few. And then as kind of sources of rich administrative data, health records really do have the potential to kind of expand our understanding of health and healthcare. However, since these records weren't really created with research in mind, they commonly lack important characteristics of patients, characteristics that could be enhanced by linking with census data. Therefore, our research really suggests that it's possible to enhance the utility of health records for research purposes by linking them with restricted census microdata. Additionally, we proposed this data linkage strategy as one means of improving the study of population health and racial and ethnic disparities in health. We can't really improve outcomes that we are unable to measure or observe, and this issue can really only be remedied by having adequate data. So really our goal for this work was to present a data linkage strategy for enhancing health data and subsequently population health. So thank you so much for your attention. I look forward to hearing your questions and comments. Additionally, we are working to get this paper out here, hopefully in the next few weeks, and it will be accessible on our website, which I put here.
Thank you, Aubrey. I think we missed the link to the paper, but maybe you can drop it.
Oh, it's not out quite yet, but it'll be on our website soon. Yeah.
Sounds good. Aubrey, really great and interesting exercise. A couple of questions. Again, we'll take a few for you now and then come together as a group and have a broader discussions. There are a number of questions about the PIC.
Yeah.
Can it be made available to other researchers? How do we, in states, for example, or academic institutions, take advantage of it. How does it work?
Yeah.
Do you mind telling us a little bit about that?
Yeah, absolutely. So yeah, the PIC is really unique to Census, and it is available in data sets that are housed within the Census FSRDC infrastructure. So those are accessible. But again, the limitation there, of course, is that you would have to get special sworn status or SSS to be able to access those RDCs. So it is because a lot of our data is protected by Title 13 and Title 26. So there's that kind of extra precautionary measure. So PICs aren't necessarily available to outside researchers broadly, but kind of to a specific group of folks that have that kind of extra step of access. In terms of how the PIC process actually works, so essentially what happens is we get data from outside sources. In this case, it would be Medicaid from another federal agency, so from CMS. And the data actually goes through, and I had to write this down, it's called the PVS process. So it's called the Person Identification Validation System. And that's the process at Census that we use when we ingest data. And so essentially we use things like social security number, name, address, and date of birth to assign these PIC IDs so that we kind of have consistency across all of our different data sources. And so with social security number, that's a deterministic match. And then when we don't have SSNs for folks, we can use name, address, and those other factors to do kind of a probabilistic match to try to find them in census data.
Excellent. Yeah, thank you for that. And we learned a whole bunch of new acronyms. Speaking of acronyms,
always.
With the data that came from TMSIS and all the talk about how good it is and how good the first cut of it was, tell us what you thought once you saw the results from these data. Surprise? What does it tell you for replicating this work moving forward? What's your reaction?
Yeah, I think, so we're using 2016 TMSIS data in part because we wanted to look at all-cause mortality. So we needed to have a little bit of a lag there. So from what I've seen from what the Data Quality Atlas has put out, which is a team that works with CMS to kind of look at these data. So you can actually go to their website and look and see what other variables besides race and ethnicity are missing at high levels, and also newer years of data too. So that's a really helpful resource. I think for us, the big piece was just understanding, what we might be missing. Because right now there isn't any regulation around collecting race and ethnicity. It's not required for Medicaid programming or for assigning benefits. So it's an optional thing at the state level, and it varies considerably across states. And so I think our takeaway really was that there's not although TMSIS really did try to create more consistency in data collection related to enrollment for Medicaid beneficiaries, there's still a lot of variation and there's still a lot of room for improvement, including maybe some changes around standardizing for collecting beneficiary information.
Follow-up question. Did you look at the relationship between the general data quality at the state level in the Medicaid data and sort of completeness in race and ethnicity? So clearly states struggled or worked hard at transitioning their data into the TMSIS format, and states, I think, did so with different levels of success. But was there a relationship at all, assuming you've looked at it?
Yeah, and I think some of that will come out when we release the paper. So if folks are interested in that, they can look at that, because we do provide estimates on a state-by-state basis. So if you're interested in a particular state and issues around data quality, you can kind of use that as a resource, kind of in the absence of having immediate access to these data outside of Census.
Sounds good. Thank you, Aubrey. I think we need to move on to Dennis, but again, for your preparation for our open Q&A, there's another question for you on race concordance. So we'll want to get to that when ready. Last but certainly not least, Dennis Linders is a data scientist on the Enhancing Health Data team at the U.S. Census Bureau, and we are ready for Dennis.
Hello, my name is Dennis Linders. I'm a data scientist on the Enhancing Health Data program here at the U.S. Census Bureau. What I would like to do for the next few minutes is to walk you through our physician-employer data linkage project, the purpose of which is to see how we can leverage the Census Bureau's data on the American people and the American economy to better understand the supply side of healthcare. This is work that I've done with Victoria Udalova, Kate Favre-Musser, and also Alice Zawacki, who you saw present a little bit earlier. So let's get going. So the origin of this project really came from this basic observation that we all know the business of healthcare continues to change at a pretty rapid pace, but we really don't know a lot about how these changes are impacting care, what the implications are for the workforce, or how they're affecting local healthcare markets. The reason we have those knowledge gaps is mostly because of data gaps, and that's because there isn't a definitive source of data on the supply side of healthcare. So there's lots of data sets that people can tap into, but each of those have different limitations and trade-offs that researchers and others have to navigate. So there seemed to be an area where we're not really going to have all the answers either, but it seemed to be a place where Census can tap into the very rich data we have on the American people and the American economy to see how we can enrich data on physicians and their employers to help to start to bridge some of those data gaps so we can start to help to bridge some of these knowledge gaps. So the image you see here depicts this vision that we have for this project of building this integrated data on physicians and their employers. We believe that we can add value in 3 different ways. So first, we're able to contribute some novel data for novel insights. So that would include, for instance, detailed information about physician income and wages, or on the employer side, lots of information about business ownership changes or detailed industry classifications. There's a second area where we can add value where we're not bringing anything new necessarily to the table, but we can provide estimates that are derived in a different and independent way from the data that already exists. So this includes physician-employer information or revenue and visit details from physician employers on the business side. And then there's a third area where we can add value where we don't really have much data to contribute. So this would include things like licensing information or billing or anything to do with patients and procedures. But this would be data that partners could bring into our environment so that we can then place that data into a new context and in that way hopefully provide some new insights. So for the next few slides, I'll walk you through how we do this data linkage work. It starts with a registry of healthcare providers provided by CMS. Then we link the physicians from that to their employers using tax records from the IRS. And then once we've identified their employers, we can get lots of rich business characteristics using Census's own business register. So let me kind of walk you through each one of these one by one. So it starts with the National Plan and Provider Enumeration System from CMS, which houses what's called the MPI registry that you may be familiar with. The MPI is a national provider identifier that has to be assigned to each healthcare practitioner, which is a process mandated by HIPAA, and this has been in practice since 2005. Today, this data set has over 5 million active practitioners, ranging from physicians to athletic trainers, and also includes 1.5 million registered organizations. Next, we then take the physicians from that data set, we run them through our internal process where we then identify them in our data sets using what's called a protected identification key. Alice has discussed this a little bit, and that then allows us to link those physicians to all data that Census has on the people of the United States. One data set that we can link it to is IRS data and tax return information. So from that, we can obtain W-2 information, which identifies both the physician's wage as well as their employer through the employer identification number. Again, something that Alice has walked us through. With that EIN and identifying those employers, we can then link it to the Census's business register. This covers 5 million single establishment firms, so businesses with a single location, as well as larger firms, 160,000 multi-establishment firms that together account for 1.8 million establishments. And it also includes information on 21 million non-employers, so that covers folks that are self-employed. The business register has information on geography. It has rich industry, legal, and organization classification information. And it has a lot of information about business activity, including payroll, employees, and oftentimes also information on revenue. This data has been consistently updated since 1972 and draws from a rich assortment of administrative records from IRS, Social Security Administration, Bureau of Labor Statistics, and even state unemployment agencies. So one of the main benefits of using the business register, with which Alice had helpfully helped introduce, is that it very explicitly splits out, tracks, and links together three main business perspectives. At the bottom, it explicitly breaks out physical points of service delivery through what's known as physical establishments. So these are the locations where the actual business takes place. Those then get rolled up to EIN tax units. So that's more of an administrative level that gives you payroll information. But then in addition to that too, they look at common ownership through this concept of firms. So you can kind of see the structure on the right here, which Alice had also given you an overview of. The only challenge that this presents in our data linkage work is that we bring the physicians in at the payroll level, so through those EINs. So we have had a need to develop an algorithm that then places physicians at specific physical establishments, mostly using geographic identifiers like known work addresses that they have, their residence information, and also their state of license and information like that. Now, there's a range of other data sets that we bring into this linkage work so that we further enrich data on the businesses and the physicians. For businesses, for instance, we use the longitudinal business database to look at changes over time. On the physician side, we get race and ethnicity information from decennial census responses. We tap into some of the CMS open data on Medicare patients and providers. But really at its core, it's the three data sets that I had walked through previously. So hopefully this is giving you an overview of how we're assembling this data and the kinds of data elements that we're able to bring into it. We'd love to go into more technical detail with you or anyone that's interested. But for this group, really what we were keen to have discussions on would be really thinking through how we can now move from building this infrastructure to really starting to make use of it to answer questions. And for that, there's three areas in particular that we'd love to get feedback on. First one is obviously, well, what are those important questions and information needs that it seems like our data is well positioned to help answer? Second question, just building from that, is what are the partners or projects that could most benefit from leveraging this new data asset? Now can we start to think about how we would structure those kinds of collaborations? And then third, another area that we're thinking about is some public data releases through dashboards and things like that. So in that case, what are some of the key facts and trends that would be most valuable for us to share publicly and also update regularly while still preserving privacy? So these are the three areas that we would love to have really detailed feedback on. And so we're looking forward to bringing this into the discussion after our presentations. So we're excited to move into this next phase of really starting to use this infrastructure. And again, for us, that's really about the kinds of needs and interests and opportunities that you're able to identify. So we're really looking forward to these ongoing discussions. If you want to get in contact with me directly, I've listed my email address here. Please also don't hesitate to visit our website where you can learn a little bit more about the other projects that we're involved in. Again, thank you for your time, and we're looking forward to continuing the conversation. Thank you.
Great. Thank you, Dennis. And I don't know if folks saw the email address, but if not, I am switching between, there it is, yeah. I'm switching between two tabs. Anyway, Dennis, thank you for really interesting and stimulating presentations, lots of questions. Maybe we'll take a couple of clarifying questions and then jump into the broader discussion. First question, and I think this is sort of like the required question of Census. Which of these data, I know you've talked about downstream working on public data sets or dashboards. But as you think about the NPAS data is public, of course. W-2 data is not. The business registry that you spoke of, is that a data set that's accessible to researchers outside of a research data center, or not? Can you tell us more about that?
A lot of the census statistics that report on businesses publicly comes ultimately from the business register. But if you want to go down to those individual businesses, then you do need to go through the Federal Data Research Center process. That is probably the most widely used data set in that environment. So it is broadly used by researchers, a little bit less by practitioners, but there are opportunities to do that. So there's a little bit of friction in trying to get access to that data. There's good legal reasons and stuff for that. But what we're trying to do here is to take the perspective of healthcare and then trying to see, well, what value can we derive from the business register within this domain? And then our role is to see how we can then create certain data products that might be of specific interest to this community. So for us, it's really kind of a three questions that we've been following. The first question is this something that we can feasibly do? It's pretty clear now that yes, we can. Second question is, well, is there value in doing that? And so far from what we've been able to assemble, it looks like there is quite a bit of potential value there. Third question for us now is to really go out to the community. And that's why we're so happy to be presenting this work and going, okay, it looks like we have something of value here. But what are really some of the key research questions or the specific business needs and stuff that we can start to build some data products around? So we're kind of at the optimal time to really go out and present this relatively early work, but so that the feedback that we get now can really help kind of direct where we take this work.
Yeah, one more question, and then I'll open it up. So many of us in the audience are work for state governments, and I think we're probably interested maybe in a brainstorming session with you on how to use the data. I think we ask ourselves daily questions about the labor force, the physician labor force. We think about particularly the mental health space. We think about market concentration and how that's changed over time. We're really, I think, curious about how ownership has shifted, not just concentration, but also to what extent private equity enters the healthcare space and what the resulting questions are. So perhaps if the Census Bureau is interested in this, perhaps NATO can convene a discussion with some state actors and bring us together and sort of do some of that brainstorming that you suggested.
Yeah, and that would be perfect because a lot of this work is governed by what they call a privacy budget. So there are certain amounts of data that we can release at certain levels of geography, for instance. But there is going to be a cap on that. And so what we want to do is if we're releasing public data tables, say at the metropolitan level, say, we want to make sure that we're reporting on those features that are of most interest to you and other stakeholders so that we're not wasting that privacy budget that will govern this work. Then in addition to that, there's other tighter collaborations we can do where it gets a little bit more difficult in terms of data sharing and stuff like that. But some of this data we could make available at those research centers. Or there's other projects that we've done where state governments share their patient data with us. We can then run it through the same pick process that Aubrey talked about. And then we can link it to the data and feedback aggregates, for instance. So a couple of different ways that we can collaborate. The deeper we go into the data, the tighter the regulations around it are. So those are things that we need to navigate. And everyone here, I think, is pretty familiar with those. But certainly, it would seem like there's things that we can release as public tables at, say, metropolitan level or state level that would answer a lot of questions that people have, at least at a high level. So again, we're at the perfect stage to start to collect that feedback. And so anyone that has specific ideas or anyone that's interested in participating in some stakeholder consultations, definitely get in touch with me by email and we'll kind of get you involved in that process.
Terrific. Yeah, thank you, Dennis. And thank you to everyone here at the Census Bureau who came out and and presented your work. It's really important that we can connect with our federal partners and that you are interested in listening to the research and state policy community. So everyone is on stage with a cup of tea in your hand or coffee. Let's open it up for question and answers, and maybe before questions come in, Alice, can you address the questions that came up earlier in following your presentation?
Sure. So the MEPS-IC sample is not longitudinal, and I several years back tried to create a longitudinal data set, and it will not support estimates given the design of how the sample is drawn. So that is unfortunate. Following passage of the Affordable Care Act, we did do a longitudinal kind of subsample of small businesses because that legislation was geared towards trying to help small businesses and with their offers of insurance. So we have from 2014 to 2016 a small sample of longitudinal cases that might be of interest. I think there was a question, Tom, I think you had another question about how we handle work from home employees. And essentially, if an establishment has employees who work from home, they're counted in our employment counts. We have not treated them any differently. Presumably, they are still, we ask about what employees, how many are eligible for health insurance, so they may or may not be included in those numbers depending upon how the employer responds. We do have some new questions that we added on in response to the pandemic where we're asking about teleworking employees and how many employees can really work under that arrangement. So we have some new content on that. And then I think the third question that came up earlier was about accessing research using the MEPS-IC. And I've worked with the sponsor, the Agency for Healthcare Research and Quality, and with their webpage designers. And I have told them, as well as the program director, that it would be terrific if on the MEPS-IC page they could put some links to the research using these data. But what I often do with researchers interested in these data is that if that is not accessible, I'm happy to respond to emails. There is, a relatively short list of researchers who have used these confidential data, and I'm happy to share details on that. We have an internal report that we recently compiled, over 60 pages of listings of research using these data, as well as different benefits for improving the survey based upon the research. It has been an internal document, although we shared it with our FSRDC administrators for potential researchers to help with people writing proposals to ask for access to these data. So there's a couple different ways that this information can be shared.
Great. Thank you for that, Alice. Aubrey, there was a question to you that we didn't get to.
Yeah, so I think Megan asked, what did the race discordance look like? How different were the reports for each data source? So I looked at our report really quick so I could get you some info. So for those who had information, race and ethnicity information in both sources, so in Medicaid data and in census data, there was actually only about 12% that had discordant race and ethnicity information. So generally, relatively small. And then hopefully this report again will come out in a few weeks. And we break that down by the race and ethnicity reported in Medicaid and then by every state. So you can get a really good sense of states that had really high discordance and states that actually had really low discordance, and how that also looks across different race ethnicity groups. So that will hopefully give you plenty of information to work with, especially if there's a state that you're interested in.
Let's see, no more questions in the chat, but a question from Norm. He asks, do you have any information, Aubrey, I think this is to you, on how race ethnicity collection or data granularity might change over time? there's a lot of discussions going on.
Yeah.
Multi-race, single race, granularity. Especially HHS has a lot of ideas about very granular data, which on the one hand are great, on the other hand are really hard to imagine that they're manageable. How are you at the Census Bureau thinking about those?
Yeah, I think there's definitely some really interesting work going on with some folks at Census who are doing really interesting stuff around race and ethnicity change over time within individuals, so kind of fluidity in race and ethnicity identification, and then obviously how it's changed kind of over the course of the history of census in terms of like how we classify that. Of course, census is really restricted by the kind of precedents and standards that are set up at the moment. There is a lot of talk about kind of changing that stuff. And I think given, issues with data collection around race and ethnicity, the issue facing states and CMS and TMSIS data kind of generally is really going to be an issue of having a consistent measure for every state. So making sure every state's asking the question similarly, because that definitely, there's been some interesting reports that have come out in recent years about how every state kind of asks the question differently. And then when in the process beneficiaries are being asked and how that could potentially impact response. So I think that's something we're going to have to continue to think about, especially for such a large federal program.
Fantastic. Let's see, we have maybe 1 or 2 minutes left. Any questions you want to ask each other? Lucy, maybe a question for your team. And I know your video isn't great, your connection isn't great. Let's see. So I think Lucy is adding that she and her team can't really speak on behalf of other offices within CMS or the chief statistician of the US. But I think if I interpret your note correctly, there's work to do and good discussions are happening. Maybe I'll close with one question since I don't see one. There are certainly statistical approaches to either imputing race ethnicity or linking data. What work do we need to do as a community to encourage the submission and the transfer of race ethnicity data? What do we have to do with employers, with beneficiaries, and whose job is it? Aubrey, I think I'm setting you up for an answer.
That's a big question for 30 seconds, Stefan.
I know.
I think that's a great question and something I'd love to kind of keep talking about later today, maybe, if folks are interested in kind of broaching that subject. I don't want to keep folks over for too much longer.
Well, we have 1 more minute.
Okay. Sorry, I'm just trying to think really quick. Would you just restate it really quick for me?
Yeah. Well, I'll maybe share sort of some of the things that states are thinking about right now. We're thinking about employer data and data and claims in claims information on race, ethnicity, and there are different layers of responsibility for collecting and responding to questions about race and ethnicity. And I think, oops, I see time is up. And I think that we just have to have layers of strategies to build understanding, recognize the legal foundation for collecting and using these data, but also demonstrating to the public that use of this data are important and essential really to addressing equity and disparities issues. So definitely let's talk about it more today.
Yes.
When we have a minute, but I want to thank everyone for a really fantastic set of presentations and for being so welcome welcoming to us to hear from the general public. That's not always the case with federal partners. So I thank you for that and for the spirit in which you've come here to us. I also am supposed to tell you that the next session is in 20 minutes. So don't go too far, and we'll see you soon. Thank you for all the great work, and I'm sorry about some of the hiccups, but overall, I think the system worked quite all right. Enjoy the rest of the conference. Thanks, everyone.
Thank you.
Thank you.